Hey guys, today's video is going to be on shock. We're going to cover the non-distributive types of shock here on the top, and the distributive types we're going to go through some physiology and some key clinical features. So as you know, shock is a disease of circulation, and it's when tissues don't get enough oxygen perfusion. And there are different types of shock. Here on the left we have our parameters we'll be assessing for each of the types. CO is cardiac output, HR is heart rate. We have left and right preload, which go by different names. So left preload also goes by pulmonary capillary wedge pressure or left atrial pressure. Right preload goes by central venous pressure or right atrial pressure. And then we have afterload, which goes by total peripheral resistance or systemic vascular resistance. And then here we have systemic venous O2, which also goes by tissue oxygen consumption. So this is the amount of oxygen that comes back to the heart once the systemic circulation has made its way throughout the whole body. So these are our parameters we'll be analyzing in our discussion. First, let's go through hypovolemic shock. Now this is a disease where we have loss of fluid inside the body. Two ways you can lose fluid. You can either lose it through hemorrhage or through non-hemorrhagic ways. So through hemorrhage we have things like blunt trauma, upper GI bleeds, postpartum hemorrhage. And through non-hemorrhagic ways we have GI losses like diarrhea, vomiting. We have burns as another example. Third spacing of fluid can be one way, and renal fluid losses. So make sure that when you are assessing hypovolemic shock, you know where the fluid is exiting the body, because that will take part in how you're going to treat the patient. The pathophysiology of this is pretty simple. When you have a loss of fluid, your preload to your heart is going to go down, both the left preload and the right preload. So the blood is not making it back to the right side of the heart, so you're going to have a decrease in right side preload. And then, of course, if you have a decrease of blood to the right side, you're going to have a decrease in blood to the left side. And because we have a decreased preload, we have a decreased cardiac output. Okay. Cardiac output is stroke volume times heart rate. So our stroke volume is going down because there's not enough volume in the system. To compensate for this, your body is going to try to increase heart rate. So heart rate will go up in order to try to compensate for the decreased cardiac output. Also, afterload will go up. So afterload will contribute to the decreased cardiac output because it has to push through higher systemic resistance. But the reason why the systemic resistance is higher is because the lower fluid volumes cause the blood vessels to constrict in order to try to maintain flow. And because there is less flow in the system, less volume in the system, the tissues are starved for oxygen. They're going to pull a lot more of it out of the blood. So our total SvO2 is going to go down. Now, ways that we can treat hypovolemic shock. First, you have to assess it. So you can do an x-ray. You're looking for, in that case, for things like pelvic fractures, hemothoraxes. You can do a fast scan, which is very effective for intra-abdominal bleeding. And assessing the person's hemoglobin and hematocrit is important in this case. To treat it, you want to do fluid resuscitation and hemostasis if the person is bleeding. And possibly you might get to the point where the patient requires a blood transfusion. One of the key things to look out for hypovolemic shock is acute renal failure. The kidneys are very blood flow dependent, so watch out for your creatinine and your BUN going up after hypovolemic shock occurs. Next, we're going to talk about cardiogenic shock. Now, this type of shock is caused by the heart not functioning properly. You can get things like myocardial infarctions affecting the heart. Arrhythmias are a big one here. Heart failure, cardiomyopathies, ventricular septal defects, and other anatomical abnormalities of the heart. And when that happens, essentially you go into heart failure. So your cardiac output is going to be low because your heart's not functioning properly to pump blood out. And as usual, when you have a decrease in cardiac output, your body is going to increase its catecholamine production to increase heart rate. So cardiac output goes down, heart rate goes up in these cases. Okay. Then here for preload, left preload and right preload, it really depends on what's going on inside the heart, how they're affected, because your measurements here will not be very clinically significant since they could be up or down. For example, if you have a septal defect, the right preload might be okay while the left preload goes up, or vice versa. It really is pathogenicity specific. And total peripheral resistance here, or afterload, will go up because, again, we're trying to maintain flow in a poorly circulating environment, just like with hypovolemic shock. And then our SVO2 will also go down. The tissues are being starved for oxygen. They're going to pull more oxygen out. Clinical features of this include tachycardia, like we mentioned, hypotension, dyspnea. Here, fluid can build up inside the lungs because the left side of the heart, if it's not pumping appropriately, will cause that fluid to back up into the lungs. So these types of shock we've talked about so far, and we're going to talk about obstructive soon, but these type of shocks are the cold types of shock, where the circulation is too minimal, so your peripheral extremities are not getting enough circulation, and the body is essentially prioritizing your central organs to keep them alive. So in these people, you will have a cold shock. This is opposed to the distributive shocks we'll talk about, which are a warm shock. So when you touch the person, they will feel warm in septic, anaphylactic, and neurogenic. The treatment of cardiogenic shock is based on the underlying disease, but definitely you'll want for these patients an ECG, cardiac markers like troponins, echoes potentially for valvular lesions, and pulmonary artery cath, so you can get that PCWP. You can assess the cardiac output and the systemic vascular resistance. So this is, for cardiogenic, you're very pathology dependent on the treatment. You can give a fluid bolus in the case where you have decreased blood pressure and PCWP is less than 15. Ionotropy can also be considered to maintain perfusion. For this, you can give something like a dopamine or dobutamine for low blood pressures. Vasopressors can also help in these situations. If you need an extra help with the peripheral resistance, you can give norepinephrine. Intra-aortic balloon pumps. If the heart itself is not getting enough circulation to the coronaries, you can put a balloon in the aorta, which helps some of the blood back up into the coronaries and perfuse them well enough for the heart to work. Complications of this include pulmonary edema, like we talked about, and renal failure. Unlike other types of shock, the administration of IV fluids in most cases of cardiogenic shock worsens pulmonary edema, so watch out for that. Next, we'll talk about obstructive shock. Now, this is caused by a lot of different etiologies, and let's go through a few. So you can have, there is an obstruction somewhere in the circulatory system. Now, you can have impaired diastolic filling of the right ventricle. You can have obstruction of venous return, or you can have increased in ventricular afterload. So let's talk about impaired filling of the right ventricle. Things like cardiac tamponade, where you have the left ventricle pushing on the right, can impair its filling. You can have obstructive venous return, which is in things like tension pneumothoraxes, where the fluid is on the pericardium is pressing on the heart, and you are not having enough return to the right and left sides of the heart. And you can also have increased ventricular afterload, such as in PE, where the right side of the heart is pushing against a embolus, where the fluid can't flow past the embolus, so it's backing up into the right side of the heart. Now, in terms of the parameters here, it's going to look very similar to cardiogenic shock. The only way we can tell the difference is by looking at the patient's profile, their risk factors, and their clinical picture. So we have obstruction either in the outflow of the heart or going from the right side of the heart to the left side. Clinical features, again, we have tachycardia and hypotension. The person in this type of shock will be cold and clammy. For this, you want to look at the heart again. You want to get an echo, CT pulmonary angiography for the PE. Definitely want to check that. X-ray in the case of pneumothorax, where the lungs could be potentially having a tension pneumothorax, air is building up inside the chest cavity, compressing the heart. obstructing blood flow going into it. And then you could get a pulmonary artery cath to see the PCWP changes. So the pulmonary artery cath, the PCWP will be decreased in all cases except for in cardiac tamponade, where it will go up because the tamponaded heart is being compressed by the pericardial fluid. So when you're essentially looking at a test question or a scenario where you have to interpret these graphs, make sure you look at the clinical picture as well, because it's going to affect how these arrows are going to move. Sometimes they're dependent, especially PCWP and central venous pressure, on the pathology the patient is experiencing. And treatment for this is based, again, on the underlying cause. For cardiac tamponade, you would want to do a pericardiocentesis. For pulmonary embolus, you want to do thrombolysis. Tension pneumo, you want to do needle decompression. And again, watch out for acute renal failure. Now let's talk about our distributive shocks. So here, in these types of shock, we have failure of circulation due to vasodilation and potential capillary leak, which redistributes the fluid from inside the vessels to outside. And we have septic, neurogenic, and anaphylactic shock in these cases. Septic shock is caused by infection. Here our big culprits are usually gram-negative bacteria, and we can look up the criteria for sepsis as the Q-SOFA score. We'll do a separate video on analyzing Q-SOFA in a bit. So the pathophysiology is a dysregulated host immune response where you have excess infection, and now the cytokines and chemokines are being released, causing vasodilation and capillary leak. In these patients, you're going to have a fever, but they can also be normothermic or hypothermic, so watch out for that. Remember, hypothermia is one of the criteria for sepsis as well. You'll have tachycardia, hypotension with increased pulse pressures, and on physical exam, the skin will be flushed and warm. There will be normal capillary refill, and eventually that will progress to prolonged capillary refill once the shock progresses. Diagnosing it, you'll diagnose it through the sepsis scoring systems that we talked about, so the Q-SOFA score. And if you do a blood test, you definitely want to look for leukocytosis, an increased ESR or CRP, increased lactate, positive blood cultures. Now here for sepsis, we have decreased preload because all of our blood is not coming back to the heart, so both our preloads are decreased since the dilation is causing it to go into the periphery. Now cardiac output, on the other hand, is going up. Because why? Because our heart rate has gone up. So in this case, heart rate is enough to compensate for the decreased preload, and we also have a decreased afterload, right? So decreased afterload is also going to help increase our cardiac output. So in these distributive shocks, watch out in septic and anaphylactic, because cardiac output will technically be increased. For treatment of septic shock, we have norepinephrine to help increase vasopressors, and because our peripheral resistance is going down, we want to counteract that. And we also have, for example, broad-spectrum antibiotics to deal with the bacteria or the underlying cause. And now one interesting thing here is to look at SVO2, or O2, venous O2 return. So you'll see that here our tissues consumption of oxygen has actually gone down, even though we're in a low circulation state. And the reason for that is, once you've dilated all these peripheral vessels, the oxygen cannot efficiently be transported out into the tissues. So it's going to remain in the circulation and return to the heart. Watch out for this. This is a common trick question. Next, let's talk about anaphylactic shock. And this is going to look very similar to septic. Again, you have to look at the clinical picture to differentiate them. So that's why I put the equal sign here, because in terms of the physiological parameters, it can have very many similarities. Now, anaphylaxis can occur for many different reasons. You can have drug reactions, insect stings, food allergies. The pathophysiology is type 1 hypersensitivity mediated, so we have IgE, which is going to bind to our antigen that's causing our allergy, and then mast cells are going to release tons of histamine, causing vasodilation and capillary leak. In these patients, you're going to have, again, tachycardia, hypotension. You'll also see flushed, itchy skin, so watch out for that. Bronchospasm and laryngeal edema are also things to watch out for. And again, patients with anaphylactic shock are going to have decreased PCWPs, decreased preload, because all of that vasodilation is going to cause poor flow and reduced blood coming back to the heart. Our cardiac output, though, is going to go up because we have decreased afterload as well as increased heart rate to compensate, and our cardiac output will be increased. Now, if you want to treat anaphylactic shock, fluid resuscitation is important. Definitely epinephrine IM is the key treatment here, and you can also give antihistamines and glucocorticoids to supplement that. Watch out for airway obstruction and cardiovascular collapse in these patients because it will happen pretty quickly. And our last one is neurogenic shock. Now, this is another warm type of shock, but this one is interesting in that it's caused by an injury to the central nervous system. And what's going to happen here is our sympathetics are essentially going to get shut down. So when the sympathetics to the heart get shut down, the cardiac output is decreased because the heart rate is going down. You have no more sympathetic input to the heart. And our total peripheral resistance is also going to go down because our peripheral sympathetics will also be impacted. So in this one, we have straight down arrows. Everything is going to be decreased. So for neurogenic types of shock, watch out for traumatic brain injury patients, people who have undergone any neuroaxial anesthesia, lumbar punctures, spinal cord injuries, things like that. So we have unopposed vagal tone to the periphery because our sympathetic tone is lost, and essentially our parasympathetics are running the show. We have bradycardia, hypotension, flushed warm skin because our periphery is vasodilated, and key treatments here for these types of patients are going to be fluid resuscitation. You want to give atropine to treat the bradycardia, and you want to give vasopressors to increase the effectiveness of your fluid resuscitation and constrict the periphery until the person's nervous system kind of comes back online. Patients who develop low blood pressure following high energy trauma, neurogenic shock is a key diagnosis of exclusion, so make sure to exclude neurogenic shock after considering hypovolemic and obstructive shock. When those have been ruled out, so if the person's not hemorrhaging or has any kind of aortic aneurysm burst or things like that causing an obstructive pattern, we definitely want to check for neurogenic shock as well. So I hope this has been helpful on assessing the physiology of shock, and let me know in the comments if you have any questions. Thanks, and I'll see you in the next one.